Hi, everybody. Thanks everybody for attending today's professional development seminar. We're really fortunate today to be able to learn from Dr. Rose Alvarez-Salvat. Dr. Alvarez-Salvat is a child and pediatric psychologist, as well as the director of training for the psychology doctoral internship program at Miami's Nicklaus Children's Hospital. Dr. Alvarez-Salvat specializes in training and development, consultation liaison services, pediatric health conditions, assessment, adjustment disorders, medication adherence, autism, developmental delays, and learning disorders. She is fluent in English and Spanish, and in addition to her other roles, Dr. Alvarez-Salvat is a practicing clinician, providing bilingual consultation, assessment, and therapy at Nicklaus Children's Hospital's main campus in Miami. Today she'll be talking with us about the role of a pediatric psychologist, and this will be an overview of the occupation in which Dr. Alvarez-Salvat will highlight real-life cases for us. Let's please give a warm welcome to Dr. Rose Alvarez-Salvat.
Thank you. Hi, everybody. Do you hear me okay? Yeah? Okay. So thank you for inviting me. I'm going to try to, let me go back a little. I'm going to try to give you as much of an overview as I can in 45 minutes. But as you can imagine, there's a lot that happens within a pediatric health rotation. And so I'm hoping at the end you have a lot of questions because I'm happy to kind of pinpoint a little bit more specifics as we go along. I also wanted to say I'm here with my fellow, Dr. Del Rey is also Nicklaus. I have a few students who are currently with me right now here as well. If there's any questions for current students or my fellow, please. Gabby was also an intern and was a student before that, so super informative for you. All right, let me get through some of the boring stuff first. So pediatric psychology, when I was looking at how we are kind of a group right now, it's not so, I would say, old in the sense that we have not been around for so long, right? So APA eventually created a kind of a mini division for those who were working in pediatric psychology. It was, of course, for those who were working in medical settings. Probably in the 80s and the 90s, the Journal of Pediatric Psychology became probably what it is now, which is still our flagship journal. And by 1980, SPP, which is Society of Pediatric Psychology, became a division within clinical psychology. And then by 2001, so only 23 years ago, we became a separate division, which is now Division 54. So I'm sure all of you follow Division 53. So we're kind of like a subset of how that started, and we're now Division 54. As you would expect in the beginning, it was all about those who worked in interdisciplinary settings, such as children's hospitals, developmental clinics, and medical group practices. It's expanded pretty broadly now. I find that all of us do a lot within advocacy. We do a lot with disease and injury prevention. You see us talk a lot about health promotion. I personally do a lot with intellectual and developmental disabilities. I'm going to give you like a day in my life kind of calendar so you see what I do. And of course, public policy supporting children and families. So where do we work? So as you would expect, we work in hospitals, and that could be either children's specialty hospitals or more rehab hospitals or more kind of general hospitals. You'll hear a lot about consultation liaison and what that is. There's a bunch of us who also work in critical care units. So anything, as you can imagine, is intensive care. So neonatal intensive care, pediatric intensive care. We have a CICU, which is cardio intensive care. And as I mentioned in rehab, we also do a lot of outpatient services. So you'll hear me talk a lot about my clinics. I do a diabetes clinic. I do a GI clinic. So I'll talk about gastrointestinal, and I'll talk about IBD. IBD is inflammatory bowel disease. GI is gastrointestinal. We do a little bit of both. And there's a bunch of other clinics that we do, including hematology oncology clinics. We also do primary care. So think of when you go to see a pediatrician and they want someone to see their patient who says that they're having a little bit of anxiety. So we have someone who actually sees cases immediately when seen by their pediatrician. I do a medical camp for diabetes, but we have people who kind of left the field and do only medical camps, which is pretty cool. We do a lot of outpatient therapy, and of course we do research. So a little kind of brief understanding of what do we do. As you can imagine, the biggest thing we do is help with chronic illness management. And what does that mean? When someone's first diagnosed with and I'm going to talk about diabetes as a lot of an example, when someone's first diagnosed with a chronic condition, it's going to affect typical adjustment, right? Whether it be overall well-being, is it going to impact family dynamics, is it going to impact how they transition back into school, overall functioning. So we go in and we assess and we try to come up with different coping strategies and obviously help with the adherence to the treatment regimen. Using diabetes as an example, there's a lot that takes place with diabetes. You have to check your blood sugar, you have to know how to count carbs, you have to know when to check your blood sugar again, when do you inject. All those little things are part of the adherence to the medical treatment. We come in and help with that as well. You'll hear me talk a lot about pain management. The unfortunate part about having a chronic medical condition is that you might also have pain. And we see kids on the floors, when I say floors, I mean all the medical floors, that come in for some kind of pain concern. Whether they just had surgery, whether they were in an accident, whether they are having a medical treatment. And the day-to-day will involve us trying to help them with different techniques. We use a lot of CBT. We help a lot with relaxation. And I, for one, am trained in biofeedback, and so we're trying to implement that as well. Everything for us is really, I would say, behavioral in nature, which means we do a lot of, think of behavioral activation. Hey, you have to do this for your nutrition. Okay, what are the different steps and behaviors that we can do to get to where you need to be for your nutrition? We do a lot with the medical team. You want them to get out of bed because they just had surgery? All right, let's sit this down and be like, all right, so number one, we're just gonna move from the bed to the chair. And then what kind of reward would we have? Oh, I love listening to music, then we'll reward ourselves with listening to a song. Things like that while they're recuperating is very, very important. We do a lot with understanding the development of the child. So as you can imagine, the way I talk to a 4-year-old who's just diagnosed with diabetes is very different than someone that I would talk to at 14. What we're expecting of them is very different as well. So we help a lot, not only with the development, but helping the family understand what they should expect and how the dynamics are going to change. There's a lot of literature on concerns with siblings, right? And so there's even like a whole kind of team that helps. We have a child life specialist team that if you're hospitalized, they'll do little workshops with siblings. Because by nature, there's going to be a shift in dynamics. The attention has shifted a bit. We try to see things in a very systemic way. And the medical system is also a system, right? So how do you kind of find your way around a medical team when one doctor might say one thing, you know that you have to go and talk to that person, and that makes kind of life a little bit uneasy for you because you're constantly being told, I have to do this or less of this or more of that. And then lastly, I personally do a lot of assessments. We've kind of incorporated a lot of assessments in our consults as well. Gabby could tell you for our HEMOC team, we do something called the PAT, which is the Psychosocial Assessment Screener, and it's widely used in different hospitals. It gives us a glimpse of what they're going through at the moment and what kinds of interventions they might need. Okay. I know it's broad, but I wanted you to get an idea of all conditions that we see. And believe it or not, these are the ones that I've seen myself. So I am the, I guess you could say, lead in consultation liaison. And that means that in our hospital, we have a 307 bed capacity, which means at any given time, we might have over 300 kids hospitalized. And they could be hospitalized for any of these conditions. And so just like all others on medical staff, they'll call us and say, we need a consult. And we have to do all of this within 24 hours, which means for those of you who are working with me, they've already learned, you get the call, someone has to be assigned to it, you have to do a chart review, you have to go and see the patient, you have to do a quick kind of analysis of what's happening, and then you got to write the reports in the electronic medical records. There's a few things that I'm going to highlight today. Anything that I highlighted is because that's what I'm going to give you case studies on and kind of tell you a little bit more about. But we will see a lot of kids for injuries, like I mentioned, accidents. We will talk a lot to the team about different like sleep issues. Of course, we are part of every new onset cancer case. We will see every new onset diabetes case. I do a lot with gastrointestinal, so I'll see not only Crohn's and ulcerative colitis, but I'll also see impaction and Caprices, things like that. I just came back from a conference, and a lot of it was on DGBI, so I don't have a lot of time to talk about that, but that in itself is fascinating. So that's disorders of gut-brain interaction. We'll talk about that when we're seeing cases. So this is just a glimpse of what a consult might be called in for. And so what is a consult? So for us, like I mentioned, we get called from the medical floor, and we're going to try to address either psychosocial, behavioral, emotional, any kind of barriers that are going to impact medical conditions or hospitalization. And I always say it's bidirectional, which means you might be admitted because you have a pain and no one knows what it is. And we come in and say, well, is there any stressors or any kind of like triggers or anything that has happened to kind of lead to this pain response? Or the opposite. They've already been diagnosed and we're coming in to help them with the adjustment to the condition as well as anything that involves, pain or kind of quality of life. We do follow the patients while they're admitted. So if they get admitted and they're there for 2 weeks, then we're the ones seeing them, ideally several times a week. And then we're doing, like I mentioned, a lot of behaviorally oriented interventions. So we'll talk a lot about how do we cope with stress, how do we deal with anxiety and pain, what are problem-solving skills that we can work with, and then we do a lot, as I mentioned, with families. So what is the parent-child interaction? And again, Gabby can explain. When I did HEMOC for a long time, that was a really big part of my process because that dynamic was very important in how a lot of the things would either get better or recuperate from the condition or going through chemo. So we used to do a lot with that kind of point of possible interpersonal conflict. And now, of course, we do it as a family. One of the things that I realized that is when COVID hit, a lot of families weren't allowed to come to the hospital anymore. You were only allowed one parent. And so what would happen is when you're getting admitted and you're getting diagnosed with something, what do you rely on? What you know, which is normally family and your support, and that was kind of removed because then only one parent could be there. And then if they were gonna kind of switch, it would be that one parent would have to leave for 24 hours and another one would be able to come back. So that was really difficult because we would come in and be like, we would want to come in and say, well, who's your support network? Bring in the siblings, bring in the neighbors. I would be like, I speak Spanish. Bring in the abuelas, right? Because they would be the ones to help out a lot. And that was something that, unfortunately, we kind of had to pause for a bit. Luckily, everything's kind of back to normal. And then the funny thing is that no one kind of sees it this way, but we also train the health professionals, right? So a lot of times they'll be like, well, this is what we need from them. And I'll be like, hold on, pause. We need to kind of get an assessment of what's really happening at home. How can we expect this when this is happening at home? Maybe the expectations are a little bit too much. And so we do help a lot with the health professionals. We do have a pediatric residency program. And so kind of aligned with our training program, we have a 3-year pediatric residency program as well. And so all of my trainees work a lot with our residents, and that's where we get the most, right? Like the work is done with them, because then they go back and they talk to their attendings and they say, this is how we do it, because psychology wants it this way. So it's super helpful to do it with residents. We used to do a lot of behavioral techniques to help with think of those who are getting LPs, the lumbar punctures, and things that were kind of painful procedures. In the very beginning, I've done this now for 20 some years. In the beginning, I would meet with them ahead of time and do some kind of exposure little by little. What are we gonna work on? What are the things that are gonna help us when we get to that procedure or that technique? They actually do more sedation now, unfortunately. But so that was really helpful. And then, as I mentioned, a lot of medical management of how do you deal with this test coming up? How do you deal with this procedure that's coming up? There's a lot of distress with the medical. And think of I always say this to my students, think of yourself anytime you've had to go to a doctor or been hospitalized. It is an uncomfortable, scary time, right? So we try our best to give them all the techniques that they might need. And then of course, like I mentioned, for anything that involves repeated kinds of things. There's a lot of repeated blood tests. You know that you're gonna have chemo in many cases for years. What is radiation? How do you get ready for any kind of like bowel and bladder management? Think of the kids who have to have the colonoscopy. So we help with all of that. At the end, I'm going to show you some of the resources and references that I use a lot, but Brian Carter is one of the main authors and researchers for Consultation liaison, and he talks about the 7 C's. And honestly, we use this for everything. We use it not only for consults, but we use it for clinics. And so kind of briefly overviewing what I've already mentioned, but we sometimes are doing a very rapid assessment and trying to understand kind of crisis mode and trying to kind of wrap it up for them and be like, okay, this is what I think is happening. Here's this little thing that we're gonna give you. Okay, now work on this. It's actually something that like the other team members don't do outside of psychology. So we will try to like not only give them coping mechanisms and strategies, but just kind of see where they're at. To then give them all the steps they need for overall quality of life. The literature of compliance versus adherence, I think, is very important. Compliance is, here's your doctor telling you what to do, you do it. Adherence is, it's more of a team. I want to hear what you have to say. What would be a barrier for you if I tell you do this 9 times in a day? It's more of a collaborative. And so the literature shows you want to have better adherence, right? Compliance is great, you're going to do what I say, but you don't have, and for kids, it's really hard, right? And most of the time, no one's looking at a kid and say, what do you want? We come in and say, all right, let's get their opinion. What is it that they're thinking, or what are the barriers? And sometimes, honestly, medical professionals will kind of make up an idea as to why they're being non-compliant. And we come in and help interpret that. There's a lot of collaboration with other team members. That's my favorite part. We work with child life specialists. We work with nurses. We work with social work. We work, like I mentioned, with trainees, with residents, fellows, obviously attendings. If you know a case, and you know, Gabby, I think would agree, that you see on the medical floors, you know their schedule as to when they're going to the bathroom. You know when someone's gone to clean their room. You know the people who clean their room. You know so much about them because so many of the professionals make it. And I'm being honest. We have professionals who are there and they're like, for example, the person who brings the food, and they'll be like, they haven't eaten. All they're there to do is bring them the plate. And they're like, I don't like it, I think. And then so we'll come in and be like, wait, they haven't eaten. And she says that she hasn't eaten the piece of bread that she was supposed to eat. So it really is a team effort. We are always, like what I mentioned, we're always trying to advocate. And we do that a lot in our hospital at both the community level as well as within our different departments, and a lot ideally championing for our kids. A few things that I wanted to mention about, I think the uniqueness about CL, I feel still to date that it's not something that is learned at school. I don't think you all have a class on CL, right? I didn't. And if it is, it was more like school-based CL. And so when we are training people, it's hard. It's kind of saying, I'm going to teach you a new language. Just be ready, because it's going to be hard in the beginning because it's different things that you've never heard of before. And it's really, I think, bringing in the medical world the human experience of an illness. And what I mean by that is so we'll go to rounds. And so let's say we're going to see someone for GI. And the way things are described are very kind of, this is a 15-year-old male presenting with, abdominal pain 3 weeks ago, and then all of a sudden, I'm like, but I still don't know what it is. Like, what is it that they have? What is it about their life? And so I feel like, find those little bits and details that help you understand them as a whole. We often say that we are kind of called to make some kind of like evaluation, but an evaluation is not necessarily a diagnosis for us. I will say we have to diagnose because we work with insurance. And so sometimes we are giving a lot of adjustment disorder, but honestly, it's difficult because it doesn't necessarily, it's medicalizing something that maybe isn't necessarily medical. And so that's why I'm saying sometimes DSM-5 is not the best with, but we do always give a diagnosis. Let me go back. So what I kind of prepared was 4 different scenarios of how we work in our hospital. One of them will be a consultation that we see on the medical floor, and that's more kind of a general CL. Another one will be on diabetes. Another one will be on HEMOC. Another one will be on GI. And then the last one, I'm just going to kind of go over pain management with you. Okay, so if you see slides don't make sense, it's because that's how I split it up. So as an example, let's say we get called for a case. We'll know a little bit about the background history. We will go into the chart and find out most of what we know medically. And then this is how we would typically write it as part of a larger template. Okay, so this is a 16-year-old African-American female who had a history of pseudotumor cerebri, ovarian cyst, stage 4 endometriosis, acute pancreatitis, and asthma, who was admitted to our hospital, secondary to headache and abdominal pain. So just that alone, right? This is no exaggeration what we might see in the case. So as you can imagine, we are asked to help with pain management and coping, and then kind of understand a little bit about it. What is it that is happening with her in any kind of psychosocial kind of area? So we find that she has some depression, some anxiety, not only due to her diagnosis, but also because she's been hospitalized, and chances are she's been hospitalized numerous times for these things. She's saying that she is kind of worried about her life, and although she's engaging in numerous coping strategies, she's really just relying on mom for guidance. So whenever she needs to talk to someone, she just goes and talks to mom. So that already tells me, okay, I'm going to give her other coping strategies to help with all these things. And then, as we already know, and I'll kind of jump ahead, pain is exacerbated by stress and by anxiety. So if we can help her with one part, ideally we're then gonna reduce part of the other. So this is someone that we would diagnose typically with an adjustment disorder with mixed anxiety and depressed mood. We're gonna offer her a lot of CBT types of interventions and give her some kinds of things that are gonna be helpful, not only while she's there, but after she's discharged. We talk a lot about the gate control theory of pain. Does everyone know what that is? Yes? No? Okay. At the end, I'll talk about it. Talking about what are the good referral sources. A lot of these kids also don't know what they're entitled to when they're in school. And so we'll talk a lot about 504 plans, a lot. We're always talking to all of our kids about 504 plans and explaining to parents that they do need extra time or they need to get up and go to the bathroom. Those are the things, or maybe like when they're in the hospital that they can get the notes and all the things that have happened while they were missing school. And I mentioned Child Life before. They're amazing. They are developmental specialists, essentially, in our hospital that come in and help with support, activities, distraction, even kind of teaching. Like, this is what a surgery will look like, and they'll come in, think of like the little bears, and they teach them how to do little things like that. So they're wonderful. We work with them a lot. I should have probably put this first, but keep in mind that when you're writing and reading these notes, this is what you're reading. There's a lot of this all the time, right? And so you're like, oh, okay, wait a second. And then at one point they'll be like, wait, no, we can't use that anymore because it's confusing. But in reality, they're using all of these. So you also, when I told you need to learn a different language, this is what I also mean, right? You're going to need to know, like, for us on H&P is like, you know, the way I say my name, right? It's so common for me, which is, you know, the background information essentially. I'll talk about diabetes in the next slide, but the hemoglobin A1C, so we're walking around saying, what was the A1C? That for us is just kind of common. So those are the things that I think also are a little bit of a learning curve on how to kind of interpret all these abbreviations. Okay, so now more specific conditions that I thought would be interesting. So as I mentioned, I am part of the diabetes team. It is the one thing that I do the most of, which means I do 2 clinics for them, like if there are other people. We work together to do a clinic. The team sees every new onset diabetes case every time someone is called into the hospital. We also see those who are in DKA, and I'll explain what that is. We actually do a camp with them in the summer. I do most of my research within diabetes. With all of that being said, for those of you that don't know what diabetes is, it's essentially an autoimmune disorder in which your body does not produce insulin, which would be type 1, or does not properly use the insulin being made, which is type 2. Insulin is a hormone that is needed to convert sugar and starches and other food into energy. It is one of the most common diseases in school-age children, and about 75% will be diagnosed by the time they reach 18. You can have an adult who's diagnosed with type 1, but it's less likely to be diagnosed. It used to be called juvenile diabetes. So we see a lot of kids who end up having diabetes, and some of the symptoms are polyuria, polydipsia. Those are the 2 main ones that kids will present with, and there might be like extreme hunger and weight loss, things like that. In what our role is, we need to know all these different things about diabetes care. We need to know about hypoglycemia. We need to know about hyperglycemia. DKA is diabetes ketoacidosis. If your blood sugars go too high, chances are ketones are coming into your urine. That causes very complicated health risks. They're always admitted when they come in for DKA. So at any given time, we're seeing kids for these. Like I mentioned, the A1C is a test that you do. It's a blood test that gives you an average of your blood sugars for the last 3 months. And so what does all this mean? If I have a case who's not taking care of themselves, so 100, for example, is an average blood glucose. Anything in the green, sorry, let me just show you here. So if you have anything between a 4 and a 6 A1C equals this blood glucose level, right? If you start kind of getting your blood glucoses a little bit higher and higher and higher, if I'm running a 2 something, my A1C is going to be an 11 when I really want it to be a 6. So already, with that information, I typically go in and say, all right, this is what we're going to do. I always tell my trainees, I know for diabetes, kind of 5 areas. You have to check your blood sugar. There's different ways of doing that, and I'll show you. You have to inject a certain amount of insulin. You have to count carbs. You have to incorporate some form of exercise, and obviously some sleep. And you have to kind of balance this all with your blood checks that you do and with your doctor. So this is a case study that is similar to what we might see in our clinics. We see, we would say, probably the most non-compliant cases we see in our clinic. They have been probably selected by the endocrinologist because their A1Cs were high, and that already tells them there's something that's not working out for them. You can imagine some kids go to school and they don't want to tell anybody that they have diabetes, so they don't inject. And I'll show you now what the little, what kind of things they use and why they may not want that being used in school. So this case specifically is a 14-year-old Hispanic male with a history of type 1 diabetes, who also presents with depression, a lot of noncompliance, and a lot of DKA admissions, which means I will see him not only in the hospital, but I will also see him in clinic. There's a lot of other stressors happening in the home, a lot of family dynamics happening. We don't attend school, at least not regularly. And so a lot of aggression and kind of overall stressors in the home. And like I just showed you in the last slide, if your A1C is 13.6, you are running high all the time. In this case, he does already have a diagnosis of major depressive disorder, and we try to give them as much, I would say, concrete steps to follow in order to alleviate some of the stressors that I mentioned, which, for example, TIR means time in range, which means what is the time amount that you've been in range that you need to be for your diabetes care. And so we do a lot of things like that. And so let me kind of show you this first. When you are using the pump, which is like top left, the middle part is the continuous glucose monitor, which is we call it the Dexcom, which is something that is always checking your blood sugar. What you see in the individuals is the little white part. And then that sends a signal to your phone, or it sends a signal to its own little device. And so typically parents have that. So the parent will be at work and the child will be at school, and it starts to beep, 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 beep. That means something's off, right? A lot of kids don't want to wear it. Why? Because their stuff starts beeping when they're in school, and that's embarrassing. Or they put it in a way that they can't really hear it, and so then they're not addressing what needs to be fixed. Over on the right is the blood sugar check. So kind of the older way was the one where you see the strips, and you would check the blood sugar, and that's insulin. There's a fast-acting insulin, and there's what we'd call long-acting. So long-acting means you take it once, and it gives you like your basal insulin, and the fast-acting is every time you eat, or if you need something to bring down your blood sugar. And then the bottom is we call it the pen, the insulin pen that kids liked to use before. And now a lot of our kids are using the pump, and they're using the Dexcom, and there's a newer version now that kind of communicates with each other. So going back to this case, that's what we're trying to get him to do. We're trying to get him to get the glucose monitor, to wear it, because you can have it, but if it sits in a box, it's not going to be helpful. And obviously checking his blood sugar as much as he can, helping with the family dynamics, getting, he is also followed by psychiatry. So we do a lot of case management with psychiatry and social work as well, and even calling school. Shifting gears again, right? We might get a consult for Crohn's. Crohn's is another, you see the theme here, there's a lot of autoimmune kind of chronic conditions. So Crohn's is also an autoimmune disease in which your bowels become inflamed and or ulcerated. It is different than ulcerative colitis. Crohn's affects one part of your intestine, and ulcerative colitis affects the other. So it is treated similarly though. There's always going to be some swelling, some kind of discomfort, pain, malabsorption, also kind of like an abnormal passageway that might occur between one bowel part to the other. It also presents similarly, so imagine a lot of diarrhea, a lot of weight loss, a lot of fever, pain, feeling kind of full or feeling uncomfortable, and overall inflammation. Like a lot of my Crohn's cases will have like mouth sores and a lot of inflammation in their face because it's an inflammatory response in the body. Another case study for this would be a 17-year-old Hispanic female who we saw, and it's MCH, so that's how old it is, okay, in 2011, who was seen for a Crohn's disease flare-up, and it included the symptoms that we would expect. And they were referred for psychology consult to help with stress management and coping. And hearing more about her story, she had just been diagnosed a few months before, and she was in the middle of studying for her AP exams. And because of her being stressed out with her AP exams, she did not take her meds. And because of not taking her meds, not only did that exacerbate her Crohn's, but so did the stress of taking it. So already we know, okay, we have to help her with the stress. We have to help her with understanding pain strategies, relaxation techniques. We wanted her to come and see us for outpatient therapy, so we offered more kind of weekly ongoing therapy. We also helped with how does she balance stress, and these are things that are kind of simple, right? Like, you like yoga, do it yoga like every morning when you get up. Do you like to listen to music? All right, listen to your music every time you have to have something that is very stressful for you. In this case, she also liked to paint, so things like that. And then, of course, referring her to the IBD. So I mentioned inflammatory bowel disease is what are considered Crohn's and ulcerative colitis. Okay. Then we have consults for pediatric cancer. As I mentioned, that is where I started. When I was a fellow, when I was an intern, I did work within the HEMOC, and then I stayed doing my fellowship doing HEMOC, and then when I came to Nicklaus, that was like my main job. So a lot of what I saw were blood cancers, so in this case, acute lymphoblastic leukemia, which is ALL, and that is a cancer of the lymphocyte-forming cells in the bone marrow. It is one of the more common that you see in kids, and it's slightly more than half of all cases of childhood leukemia. There's other leukemias, this is the more common one. The treatment entails typically 3 years of a course of treatment that can include different kinds of chemo, as well as radiation. It is the best prognosis of all the leukemias. There's also a lot of research on, depending on the age in which it's diagnosed. So again, I'm giving kind of like a broad overview. We see a lot of brain tumors as well, and the treatment there might look a little bit more for the more blood cancers, but it's also very, we would call specialized and directed. So surgical, some need a shunt, a lot of radiation. Some of the symptoms, of course, are what are also dealt with for us. So meaning we help with some of the pre and post treatment types of presentations. Think of the nausea, the kind of affecting of the sleep as well as the eating. And then, of course, we see different kinds of, like, not only bone tumors, so osteogenic sarcoma, osteosarcoma, we see a lot. So you can imagine there's been some who present with amputations, and others that are more soft tissue solid tumors. So rhabdomyosarcoma is one of the most aggressive cancers. So this is similar to how you would address, for our team, we have a HEMOC group. So students don't necessarily go in and see HEMOC. And the reason why we switched that years ago is because these cases need follow-up sometimes daily. And students, it was too much for them to do that. But a case that I wanted to present, which is kind of similar to ones that we see, is a 2-year-old that we saw, an African-American boy who was admitted to the hospital because of vomiting, a shunt malformation, and because he had was already diagnosed with carcinoma, which is a different kind of brain tumor. And then in this case, we were asked to help more family and offer support for mom. And so he was diagnosed with this when he was a lot younger. So he presented with seizures. When they did evaluations, they determined that he did have a mass, and when they did more procedures, they found that he did meet criteria for a tumor. He then developed hydrocephalus, which is when fluid builds up in your brain. So you get a shunt, which essentially is, I'm going to kind of simplify it, but like a tube that basically allows the fluid to not swell in your brain. And then he also had Li-Fraumeni syndrome, which is a genetic syndrome that basically you will be very likely to continue developing different kinds of cancer. So as you can imagine, that was a big need to help with mom and support as much as we could. At the time, he was getting chemo, but he was also now presenting with, like I mentioned, the shunt malformation. He also presented with a lot of delays, right? So there was a lot of delays in speech, a lot of delays with feeding, motor coordination, as well as walking. So he met the diagnosis of GDD. And in this case, we were offering a lot of support and therapy for family. We were also trying to get them connected with Early Steps. For those that don't know Early Steps, it's the Florida program for kids 0 to 3. And they'll do a little bit of a screener to see what areas of development need to be helped. I actually had to do that. I did that for like 6 years. And then we were also trying to get them connected with our feeding and swallowing team because he wasn't eating as well. How are we doing in time? We're good? Okay. And then lastly, because it was kind of like not one case, everything I've talked about seems to have brought in things with pain. So for those that didn't know about the gate control theory of pain, so we always talk to our patients about the idea that pain is regulated by our brain. And so your pain might feel like a 10 and might feel like a 5, and we're both saying we have headaches. So it's very subjective, it's very personal, but it's very real. And so a lot of times what we try to explain to our team is, I don't want you to automatically say this person doesn't feel anything because they hurt their toe, right? Whereas this other person is saying, I just did a full, spinal surgery, and they're saying they have nothing. And so everything we try to do is very individualized when it comes to pain. It is both physical and psychological. And obviously feelings and thoughts will increase pain. And what I mean by that, for those who don't know the gate control theory of pain, is that you have to think of it as basically our brain stem is basically full of nerves that basically when you are doing things to help alleviate the pain, we are closing the gate. And so by closing the gate, we mean what are the things that you could do that are distracting, relaxing, helping with pain management. If you're very focused in the pain and you're constantly like, oh my God, this is terrible, I can't do this, then of course you're gonna feel pain more. So that's how we come in with a lot of products, I guess you can call it. We have, luckily, a lot of donations, and so people will give us coloring books and things to paint and things to squeeze and things to bounce, and whatever it is that we can bring them to help with pain, we will. And then we use the FACES scale, so this is for little kids. Think of kids that don't really know 1 through 10 yet, right? So when you're showing them this, you're using the FACES and saying, all right, what do you feel right now? And to be honest with you, we don't discharge when they're down to a 0, right? So we also help them understand that pain from 5 to 4 is still okay, that we're still gonna we're working towards something, because a lot of times parents will get upset, they're like, they're still complaining of pain. We're trying to alleviate to a point where you can go home and still kind of continue these strategies. I promised you a day in my life. So, that was fun. We work by weeks. This is how I kind of see my world, right? Like what week are we? This is week 4. We have an extra week next week because somehow it turned out to be week 5. We're very excited because that means none of this stuff is happening. Like I mentioned, I have certain clinics throughout my month. And so I think I'm currently doing about 9 different clinics. I didn't mention neurogenetics, but neurogenetics is a clinic that we do with neurology and genetics. And it's for kids who do have a genetic condition that is impacting neurological development. And so we see a lot of cases who have a lot of physical disabilities, a lot of nonverbal, a lot of autism in that case. And we also help with a lot of resources. The other ones I talked about, so I do, like I mentioned, diabetes clinic. We always do diabetes clinic with our endo team, which means we go down to their office, we all meet with the patients, and that clinic will have a social worker, a diabetes educator, the endocrinologist, nutrition, and ourselves. It's actually my favorite. And then I just started doing like a follow-up diabetes clinic. I noticed that whenever we see them in clinic, it's never enough. So then I offer kind of like, remember we talked about this for like 12 minutes last time? What if we kind of do a half-hour stretch on, what are the things that we need to focus on? I also do a lot of testing. It's probably one of the other main areas that I do. So I'll do assessments on young kids mostly. I'll see a lot of the younger ones. I do diagnosis for ADHD as well as autism. I'll use the ADOS, so my trainees will get to learn that as well. And I have some therapy cases. Am I missing anything? No. In case anybody wanted to know how I got here. So if you go from like bottom up, so I became board certified in 2021. They don't have a pediatric psych board certification yet. So I did do child clinical and adolescents. They will though, and so I might have to just do this again. My research interest started when I was a fellow because I was an NIH postdoc fellow, which means you had to focus on one area or theme, and for us it was the minority health and health disparities. So there was one of us working on cystic fibrosis. There was another one working on special immunology, which is more like HIV/AIDS. I was working on diabetes. Someone was working on HEMOC. And so that's where my, and I didn't even touch upon what are the main kind of goals that I have, which is I work with most minority and underserved populations. And one of our clinics is dedicated to African American and Hispanic and other ethnic minorities because the Dolphins grant, meaning the football team that many people live here, gave us a grant to provide services to sickle cell and diabetes youth. So that's one of our clinics. And then, as I mentioned, I did both child clinical and pediatrics when I was an intern and a fellow. I studied in Boston and came back to Miami. You're going to have this, I believe, you're going to have this available to you, but I wanted you to know that we look into these as resources all the time. So if I have a question about, so think of these kids that I see that maybe don't know anyone else that has their condition. We see kids who are not necessarily from Miami. And so I will find maybe a group or a workshop or something closer, like ADA does a lot with like workshops in Orlando. And so they'll do kind of like a convention. And so sometimes it's really nice for the kids to learn. We give a lot of resources and printouts. Every time we see someone, we're like, you know what, here's something to work on. Here's something that you can continually learn about. Nicklaus now has its own resource. So in our department website, we have a lot of things that you can also look into. Like if you want to learn about anxiety, if you want to learn about diabetes, we have them there as well. And then pedpsych.org is the SPP website. In case you're interested in how would you start, okay? I would say reading about consultation liaison, like I mentioned, Carter's book. The Handbook of Pediatric Psych is kind of our go-to for everything. In every chapter is dedicated to one of the conditions that I mentioned in that long list that I showed you. Joining Division 54 listserv is one of the things I always tell. If you're going to work with me, you should be part of that. It talks about, you'll learn about all the different hospitals doing all the kind of great work that they do. And then ideally joining SPP. They have a resource bank available now as part of their website that if you're a member, you can then, different people have uploaded different things that they've loved, either different presentations or different worksheets, different strategies, things like that. By being part of SPP, you'll get the JPP. They now have a clinical practice in pediatric psychology journal as well. And then, of course, you get to, if you want to, attend the SPP annual conference, which we encourage all of our people to do. And that's it. Okay, I'm going to take my glasses off now. Please tell me your question. Yes. Hi.
My name is Melissa Jordan. I'm a third-year student. Actually, when I was in high school, I volunteered.
I was like, you look familiar.
So
Yeah. Yeah.
excited to hear about
That's
this
great.
I wanted to hear a little bit more, if that's okay, about the training process for
Mhm.
students working with you, the consultation liaison, and how it starts.
Sure.
Do they get to shadow resident students first, or how that goes?
Yeah. So we have a 3-tier training program, which means we have fellows who are done with internship, Gabby, who are getting their licensing hours. And then we have our internship, and we have a pediatric health track, and we have a neuropsych track. And then our practicums have numerous tracks. So the way that I organized it for FIU, this is when Dana was kind of helping me organize it for future students, is that we do it by like different rotations. So our pediatric health rotation for a student would automatically mean that you're going to do consults. And so what that means is, I think I don't remember off the top of my head, but let's say like 10 to 12 hours of your week are doing consultation liaison service. And then I always say you want to kind of add one of the other things that I'm doing, meaning you can do pediatric health clinic, which is the clinic I do that is kind of a post-consult clinic. Let's say you were diagnosed 2 weeks ago and you want some kind of follow-up with what we did when you were admitted, you go to that clinic. Some others do diabetes clinic with me, which means then you would be doing either a Thursday morning, one of the weeks, or you'd be doing a Tuesday afternoon. So that's roughly, I have a few students here. That's roughly how they do it. I guess I'm old school in the sense that I always encourage to come in and kind of learn as much as you can. So if you can say you did consults and then you could do a clinic and then you picked up an outpatient case because you're really working on the things that I was mentioning with certain patients, I feel like that's a really kind of well-rounded experience for a student. So that's how we do it. And I mentioned the other trainees because we all do things together. So another psychologist and I do a Monday group supervision, and there's probably about 15 of us, would you say, that get together and we do our own rounds, which means everybody presents, not everybody because there's not enough time, but everybody presents on cases that they saw on the medical floors. And so we get used to kind of learning about, these are the different presentations. If she's been doing a follow-up, we get to hear what's been happening in the last few weeks. We have medical residents also sit with us in supervision. So that's another, I always say it's like the one gift COVID gave us. So American Academy of Pediatrics, had to shift things around during COVID because they also didn't have enough rotations for their pediatricians who weren't, or pediatric residents who were not being able to go into hospitals as much. And so what they learned too is, lo and behold, mental health was important, right? So they wanted them to learn more about mental health. And so they now rotate through psychology. And so they'll rotate with me for consultation liaison, and then they might do one of the clinics. And they just sit there. These are MDs. They sit there and they listen to what we have to say and what we have to kind of teach about development and psychosocial stressors and how do you deal with difficult patients and how do you deal with things that we are kind of used to but they're not. So that's another part that the students will also be exposed to. Does that answer your question? I'm like super long-winded, so I'm sorry.
No, thank you.
Hi, thanks so much for your talk.
Mhm.
I'm wondering, I feel like the 7 C's, specifically, I
Mhm.
imagine the changing systems
Mhm.
C
Mhm.
can be especially challenging both
Mhm.
to find time for and also to find levers for change at that more systemic level.
Yeah.
I'm curious if that's something that you've been able to if you have an example of something that you've done within that
Yeah.
category.
I'll start I always think Braun from Brenner, right? Let me start locally and then,
Yeah, of course.
so a lot has changed in our hospital, so I'll start with that. So just when I was first hired, the idea of why you would even call a psychology consult was very foreign to most people. Believe it or not, one of the things that I have to train my students is you're gonna be told, why are you here? I'm not crazy. No exaggeration. And so we started with, like I mentioned, first we started with residents. And then we started with fellows, meaning non-psychology fellows. And then I started meeting with all the attendings and basically saying, this is when you would call a psychology consult. The same way I don't know if an injury of a leg needs an orthopedist and you call them, I don't want you to determine who needs psychology. I'll determine who needs psychology. And so that level of training, I felt then did shift the system of what is psychology in the hospital? Why is it that we need you? And fast forward to now, any new hire of any medical doctor, if they so much as mention, I want psychology part of our clinics, because at this point we have, I only mentioned mine, but we have about 23 clinics, which means there's someone also doing all the hematology oncology clinics, and there's someone doing headache clinic. There's someone doing a feeding and swallowing clinic. If you are hired, you cannot get hired without knowing if there's a psychologist available to you. And if you want one and that person's not available to you, you may not get hired. That's how we set up the medical staff. Because what was happening is that they'd be like, can you come and see this patient? Oh, could you? And now we have it so organized that everyone knows from the beginning to the end. If you get diagnosed with this, you're gonna get psychology. And if you're gonna need someone ongoing, you're gonna get psychology. And if you have any kind of risk factors, you're gonna get psychology. And so I feel like that, for me, was one of the bigger growths that I saw when I was first hired, that you would get one consult a week, right? Because I didn't know any better. Now, we will finish the year, how many are we? 1,000-something consults a year, not including follow-ups. So, we're working hard at it. Mm-hmm.
Thank you.
Yeah. Hi, Lynn.
Hi, Dr. Rowe. Thank you for the presentation. Just full disclosure, I am a student. I'm a little biased. Really enjoyed this presentation. But I guess I was wondering if you could talk a little bit about the cultural considerations of doing consultations and whether or not you think it's maybe opened the doorway for more acceptance into mental health, especially among certain communities.
Yeah. I know, that you say that I really wanted to do only on the colon part, but I was trying to see how much I can give you at the same time. So again, I think kind of individually, and then I think community, and then I think department-wide, and then I think kind of like our area where we actually are located. The other thing that I try to do every time we're seeing a case is understand, like I mentioned, what system we are working in. And so if I am coming in to see a patient, and this happens often, unfortunately, is if we're not taking into account someone's cultural, religious, SES background, and then saying, go do this, you're going to miss the areas that are in need of future attention or current attention. And so what we've also tried to train residents and fellows and attendings is you have to come in understanding what the family needs and where they're coming from and what they're going to come back to. Using diabetes as an example, you've already seen that clinic. And maybe you've already seen it, that there's this kind of understanding that, like, what's the big deal? Just get it done. Well, when you have someone with, like, you know, food insecurity and low resources, and in a community where we can't tell them to go take a walk, when there isn't enough money for certain things, when there isn't enough awareness of certain things, when there is no transportation to bring them to clinic, we have to do as much as we can from that angle. And so remember, my research was more health disparities. You know, I would love to go back to what we used to do, which, you know, in the research projects that I did, we would walk with them to certain areas. We would take them to a grocery store and say, all right, what would you pick here? Tell me what you need. Well, how would you budget what you need to do what you can here? The cases that I see are normally, like I mentioned, from ethnic families. And so we do have some, you know, hopeful, like, resources that we're trying to get with social work, but that is why I try to do as much collaboration with all these other disciplines as I can. I know people have asked, like, so what do you do specifically? I just feel like I always think of it. I am always talking about it. If there's a language, as you already know, we try to provide it in the language that they're going to understand. I can't tell you the amount of patients I've had, they're like, I have no idea what that doctor just told me. Yeah, and then you're like, what? Then they're going to go home and not know how to do these things? You probably saw this the other day. The residents said they had never used an iPad. We have an iPad with translation services with every language you can think of, and they had never used one. I'm like, well, you must have encountered someone that didn't know how to speak the language. We are also 60-some% Medicaid. We serve a very diverse population, not only from Miami, but think of, like, South America, the Caribbean. And so we have to always take into account. We've had numerous patients that don't want to ask any questions for a doctor. And so we've found other ways to help them, be like, can you write it? And maybe if you write it, we'll ask for you. So little things like that, but every case has to be individually attended to like that. I told you I talk a lot. Sorry.
Hi, my name is Anid. I'm a second-year doctoral student in the program. You briefly mentioned your area of research, so I'm curious on how your plate is divided and how you handle
It's full.
consultation, right? Consultation, clinical, and what does research look like
Yeah.
in your role and setting?
Yeah, I mean, it is probably one of my own barriers. So we are more of a clinical site, but you'll find that, thanks to Dana, we have a lot of other opportunities sometimes for research. Mine is kind of clinically indicated, which means if I see patients on the clinic, I should have said this, when I see patients in my diabetes clinic, they automatically get a PHQ-9, let's think of all the other ones, PHQ-9, a GAD, a DEPS, which is disordered eating scale, and now we just introduced the PEDS-QL, which is quality of life. And so I talked to you about, like, the conferences. So one of the things that we're looking at is what are the different variables that are highlighted in these different questionnaires are going to decrease your hemoglobin A1C. So if you're coming in, of course, like, it's kind of predictive, right? Like, if you have a high anxiety level, if you have high depression, if you have disordered eating, chances are your A1C is not going to be where you want it to be. So then we also look to see where is psychology more involved in those cases. And so probably the last 5 years I've done some presentations at SPP, and they're more honestly about that. How do I fit it in? Because I'm in clinic, and so we're collecting data. I don't know. I write on the side. I don't know. But it's not that I have it kind of carved out like every Friday, yeah. And other people have done different kind of research. Like we had the PCORI grant, they were seeing cases for anxiety. Yeah. Go ahead.
I was wondering if you could speak a little bit about the dynamics in specifically a hospital setting of having to work with children, but children that are already a population that are so dependent on parents.
Mm-hmm.
So how much of that intervention is relying on parents and communicating with the parents and doing work with parents,
Yeah.
teens,
All of
children?
it. Yeah. Like I mentioned, developmentally, of course, it's gonna change it a bit. Every time we see a case on the medical floor, we do contact the parent if they're not there. Some doctors don't, but as a psychology team, we always call the parent and say, listen, your son or daughter was here, and we were assessing for whatever. Is there a time that you're going to be here? And so I always try to either make that connection or get there when they're going to be there. When it comes to the family, yes, everything has to be communicated with. I mean, think of just legally, there's a lot of things that you have to take into account when you're working with kids. There's a lot of things on how you're going to document things. The one kind of thing that's interesting is that when they're admitted, they're not there for psychology, right? So if you come into a hospital because you had back pain, chances are you're going to see an MD for your back pain. You don't really know you're going to get a psychologist. But the good thing is that you do give consent. As soon as you're hospitalized and your child is being hospitalized, you've given like a blanket consent to have different disciplines come see you, psychology being one of them. So it's not necessarily always a surprise. So that's very helpful. And then the way that we always present is, I say this all the time, how fortunate for you that you have psychology as part of the team here. And we're just here to see you for X, Y, and Z. And we talk a lot about a lot of times that is the reluctance, that if you're a student, you're going in and they're like, what if they say no? What if they don't want to talk to me? And what if the parent just asks a lot of questions? So we help train with like, what do you say? How do you, and we do a lot with the family. Just yesterday I was calling a mom because she wouldn't come to the hospital, so I had to get a hold of her. So somebody else had their hand up.
Sort of relatedly, that's on the other side, like you spoke a lot about how you work through residents and using them to get to the medical staff and things like that, but I'm curious if you could speak a little bit more about, when you are working more directly with doctors, like even if it's psychiatry and things like that, how you approach that relationship and educate them about psychology and all that.
I mean, I'm probably spoiled in a way now because I think as you can imagine, I interview a lot of people every year and I get to hear about what it works like in other hospitals, and I do hear a lot of, there's a reluctance and there's not a lot of like people calling, for something, or it's very separate. I feel like in this hospital, everyone knows who we are and what we do, and they're always calling us, and I think that's proven with how many things we're part of right now. So that's why we have so many clinics. So I don't feel the, let me see if I can get a hold of blank. There's certain disciplines, of course, that are a little harder than others, but I don't know, would you say it's, since you've been there already a few years, would there be any disciplines that are a little bit harder to get in touch with or to respect us in a way? I feel like everybody kind of knows.
I don't think disciplines is a whole, there's a lot of
Yeah.
personalities.
Yeah, there's a lot of personality, that for
But
sure.
We're like I'm thinking of on Thursday mornings we have multidisciplinary rounds for hematology and oncology, so we're like on the hemo floor in rounds with the attending, and they go patient by patient to every room, and they go psychology, child life, social work, PT, OT, and it's very interdisciplinary in that sense.
Yeah, that's why I'm saying I might be not the best to answer because I feel like everyone's kind of like, no, can you be here? And everyone has each other's like cell phones, and I've never had a problem calling someone directly and just saying, this is what I worry about. There's times that I'm seeing a case and they want to discharge, and we'll say, I don't think they should be discharged, and they'll be like, okay, we're not going to discharge them. I mean, that's pretty powerful, right? So, or I'll say, listen, this is something that you don't know. I'm not going to put it in this chart, because this is the other thing about chart documentation. When you're seeing someone on the medical floor, everything is available to everybody else to read. It's what we'd call just a consultation note. If you're seeing someone outpatient, then it's secure. And we've run into a few issues where if you are seeing cases outpatient, then they won't know what you did when you see them in the floor. So they might be like, oh, you're not doing anything. And I'll be like, I have 45 notes that I saw this case. But they don't know because they can't read it. And so I make a big deal about like, we're gonna go talk to residents first before we see a case. I'm gonna tell you everything that we know, either about what we're gonna do or what we know about the case, and then I like overly communicate. And so that is super helpful, I think. And like I mentioned, no one's ever been like, you know, we don't need you. I think it's been the opposite.
All right, I'm just mindful of the time.
Okay.
We have lunch already set up in 1:35, so I'm really excited to continue the conversation informally. But please join me in, again, thanking Dr. Rose-Salvat